Welcome, everybody. We'll be starting in just about 1 minute. We've got a really big crew on here tonight. Excited to talk to you all about medical insurance billing. Kind of a different webinar than we've done before, right, Rich?
Yeah, a little bit different, Why do we change it, Guy? Because it's changing, right? I mean, the payers, they make sure that this is a moving target. They're the ones with all the money, and they're the ones making all the rules. So we got to just figure out, what's the best way to do it, and that's why we keep changing it.
Yeah, and I think what we've found is that most offices are out of network, and so we're going to focus on that tonight. And we'll start promptly at 8 here Eastern in Florida, where I am, and I guess it's 7 there in Texas. Rich?
It is.
All right.
We're waiting for our first cold front to come through. It's been hot here, man.
I think you'll be waiting just a tad bit longer, but well, I think my clock's turning over to 8 right now, so let's get started. We'll go for about an hour. I think we're going to get a lot of information here that you all will really find valuable, and then we'll stay on to answer any questions. In the meantime, if you have questions, type them in the question box. We'll be answering those as we go, and we're really excited to get going and talking about billing. We talk here at Dental Sleep Solutions and DS3 a lot about what we call the 4 pillars: screening, testing, treating, and billing. And tonight we're going to concentrate on the 4th pillar, which is billing, which fortunately or unfortunately, depending on how you look at it, it has a whole lot to do with insurance. And Rich, I think you gave me this slide a long time ago. I think this is probably really one of the more important concepts to get across.
Yeah, it's almost a paradigm shift, Guy. I mean, I know you put together this PowerPoint. Thank you for doing that. You got a lot of really good slides in here, and I'm looking forward to sharing this with people. But I think everybody out there needs to understand from the get-go that we're not doing dentistry here. We've crossed a line, and we have a dental solution for a medical diagnosis and problem. And there is no code we can file in dental insurance to do this. It has to be medicine. So I like starting at the high level, Guy, and then we get down. That's kind of how you've designed this PowerPoint, and I like that. So, but you got to get through your mind right now that it's just different. And we're trained to be a dentist and work on teeth, right?
Yeah, I mean, I think I don't think most everyone on here tonight is involved in dentistry, and most of you are dentists, and so I wouldn't imagine that anything on this screen makes you too nervous. Even taking a sharp needle and sticking it in someone's gum doesn't make any of us nervous, and that's because we're used to it. We're trained to do that. But what about if you had to go represent yourself as an attorney? Let's say you're getting sued for some reason. Would you feel comfortable going in front of that judge there without a help from a legal counsel, or doing your own plumbing, or building your own house, or even maybe do you do your own taxes, fly your own plane? Now, some of you may do some of these things, but I could tell you, the thing that scares me the most is that one in the middle. I don't think I'd want to do my own taxes, And why is that? Because we weren't trained to do this. We don't have experience. We don't do it every day. Both my sister and my niece are accountants, and it's not that they're much brighter than me, which, off the record, I don't think they are, but it's that they have training, and I would much trust them more to do my accounting, because that's what their expertise are. And I think we'll start by saying, that line in the sand that Rich was talking about, you've crossed it the moment you start billing medical insurance for a dental procedure. And if you think, well, I bill dental insurance, it's the same thing. It's as different as flying your own plane as it is from walking down the street. It's totally different, and you're going to have to really learn a lot if you want to do your own medical billing. And so I think the take-home message we'd like to express, and this isn't a cop-out, it's the quick and honest answer, is if you're going to do medical billing and you don't know anything about it, you haven't done it in the past, using a third-party biller, a company that's what they do, is they do medical billing. A lot of companies do medical billing for dental offices, and you can contact us. We can hook you up with multiple companies that do that, and that's what you need to do, at least when you're getting started. Having said that, that's not the only answer, is it, Rich? I mean, we're not just going to hand this off to the medical billing company and think that's all there is to it. Is there a little more to it than that we're going to talk about today?
Even to be successful doing this, that third-party biller is going to say, hey, guy, how come you didn't get the patient sleep study? Wait, you got to know what right now you don't know what you don't know. So yeah, we've got to, and we always try to give you all the best and most up-to-date information that we possibly can. So I like what you said there, Guy. It's not a cop-out. I think sometimes some of us have a little chip on our shoulder, in some ways, and man, I can do this. I can fix that sink, and 18 trips to Home Depot later, you finally call the plumber and go, okay, I don't have all this stuff. Yeah. That's kind of the way it is.
You might be better off taking your time to cut a crown prep and paying that plumber than to take all those trips to Home Depot.
Well, and that's kind of the way this is too, though, Guy, like you said, so, 6 months from now, 12 months from now, you'll know a whole lot more about it. And maybe you can take over some of this right now. So this is not a cop-out, but we're still going to talk to you about how you can do it.
Yeah, and even if you're going to use a third-party biller, you're going to need certain things in place. You're going to need proper medical billing. You need to have some medical knowledge. There's a lot of gray areas in medical billing that you're going to have to get experience with. So it's not going to solve all the problems. And if you don't have some of this knowledge, in addition to using a third-party biller, it's going to result in non-payment. So what we're going to talk about now, just for a couple of minutes, are some of the things that we can do to help you be prepared for medical billing. And again, there's more to it than just the actual billing. And a little bit about why, Rich and I are talking to you. Why are we qualified to talk about this? We're going to give you some really good advice about how to do out-of-network billing in particular. But for just a moment, we'd like to delve into why we're here, and why do we think that we have the ability to help you, and I'm certain that we do. This is pictures of Rich and I. I'm the guy on the left of the screen, Rich Drake on the right. We've known each other for, over a dozen years now between us. We've been doing 14, 15 years independently of dental sleep, maybe more than, I guess more like 15 or 16 now. So over 30 years of experience in doing dental sleep. We've done thousands of devices. Rich is even busier than I am these days. How about how many devices you do in a month now, Rich?
We're getting close to doing 100. So
wow. Also,
that's a lot of work. That's a lot of medical insurance claim for. So yeah, we are qualified to do this. And Guy and I got together and we started, the Dental Sleep Solutions Company, and we have evolved and we've changed over the years. And I love our mission statement there. We're the most trusted, innovative, customer-focused provider of solutions in dental sleep medicine. So, and insurance is just one of those things that you have to learn about. So, and we have put together what we call our DS3 Experience. That includes all of these things, from education, coaching. We actually have a web-based software that's dedicated to sleep and TMD. So there's all kinds of things, and we really try to get our arms wrapped around this entire process and try to help dentists become successful at doing it.
Yeah, and by the way, you may have some questions throughout the night. We're going to really, we'll type those in as you're typing, and we're answering some as we speak, and we'll answer some at the end. And if you need more details and just want to talk to somebody, just type in consult tonight, and we'll give you a free consultation. We have a room full of just trainers, dental sleep experts that can help you. And if you want to sit down and talk to one of them about your challenges and how we may be able to help, just type consult. It's no cost. You'll find it very valuable experience. So, and we'll mention that again a little bit later. Also, we do teach courses all over the country. I just got back from California. We're teaching them, as you can see, the dates here. Some are 1 day, some are 2 day courses. I can honestly say you'll not find a more implementation strong course in the country. We teach you how to do this in your practices, the practical things that you need to implement dental sleep. They're very reasonably priced to start with, but for the people who attend our webinars, if you just type in course, and if you know which a city you want to go to, just type that too as well. But you can just type course, and we'll secure a discount of $95, I think, that we give off of the 1 day, and $200 off of a 2 day course. And the 2 day course is priced under $1,000 to start with, and the 1 day course I think is about $400. So it's really a very reasonable course. And if you want to come to any of those, I'm sure you'll be happy you did. And last bit of kind of course information. Rich, last year we put on our first symposium almost 300 people there. I know we'll top that out this year, and it was just some of the best speakers in the country. Clearwater Beach, Florida, in February, wherever you live, it's likely a little nicer in Clearwater in February, and we have a really good room rate. If you're interested in coming to the symposium, it's a really a great event. That I know you'll be there again this year, Rich, and you're bringing your team with you this year too.
Yeah, they're tugging on my shoulder, man. Come on, why can't we go this year? And I think I am. I brought a couple last year, and the ones that didn't get to go were very upset. So because the ones that did go talked about how wonderful it was. So yeah, and plus, for you Northerners, February is Florida is a great place to be in the middle of February. So can't beat it.
It's a little easier for me because it's just a drive, an hour drive for me here for my team. But we'll be there. It'll be a great time. A lot of just real practical information. If you talk to anybody that went last year, they can affirm that it was a great experience. So again, this is what the DS3 experience is all about. We recognize that in order to implement dental sleep, you have to have a system, training for screening, testing, treating, and billing. And we help our practices through education, coaching, software, and support. For a very reasonable fee. And again, if you want more information about that, be sure just to type in consult, and one of our trainers in particular, Jody or Brandy, will likely follow up with you, and I think it'll be worth whatever amount of time you want to spend talking to them. We'll be doing another webinar on which device to use on August 29th. We're going to talk about some of the newer device designs that are out there, some new Herbst arms that are coming out, and some cool things like that. And so, which devices do we do? I think we've learned a few things. Rich is doing 100 devices almost a month nowadays. We've learned a little bit about which ones work better in most places. So we'll look forward to maybe having you back on board with us then.
Yeah, those are probably the two most asked questions we get, Guy. How do you do the billing, and which dental device do we make? So those are our next two webinars. So you're getting half of that tonight. We hope to see you in a couple of weeks, at the other one. Right. And, this is a hard thing for dentists to get through their mind, isn't it, Guy? We talk about, what we do and what we charge, and, dental, we expect to be paid our full fee. Sometimes we get discounts, we do that, but this is what I charge the insurance, this is what I do. And medical's different. I went in, Guy, to get some blood drawn the other day, and I said, hey, Wade, I want to know how much this costs. And well, I don't know, and I was kind of a bugaboo about it. And, by the end, the little phlebotomist there goes, look, we just draw your blood and we bill your insurance, and they pay us, and you pay us or don't pay us, whatever. It was just like, there's just a different mindset. And what we have to remember is that patients feel differently when they're doing a medical procedure than when they do a dental procedure as well. So where did you find this ADA Code of Ethics?
I've had it from the ADA, and I think the key point here is, we want to do what's right for our patients, and I think that's where the ADA Code of Ethics comes in, and what's the ethical thing to do. And we want to do that for our medical patients as well. And we have to think about this a little differently. Medical can be life and death, and some people don't have adequate coverage. Do we just tell them to hit the road when that's the case, or do we do the best we can to make it affordable? And so when you think about the way the ADA came up with the Code of Ethics, it's a little different, because we're talking about, I'm not minimizing teeth, but for the most part, it's not life-threatening. And so the ADA Code of Ethics says that, I'll just paraphrase it, that a dentist who accepts an insurance payment as payment in full without telling the insurance company that they didn't collect the co-payment or the additional amount, that's considered overbilling by the ADA. So I think that's very familiar to most everyone on the call. So in other words, you bill insurance and they allow X amount, and you collect from the patient, but you don't collect the full amount from the patient, but you collect the full amount from the insurance company. They consider that overbilling. The American Medical Association has almost, I would consider it pretty much exactly 180-degree difference here. And they're basically saying that patients are made aware of costs through these co-payments, but if that co-payment is a barrier to needed care because the patient can't afford it, the physician should forgive or waive the co-payment. So in other words, they're not saying that it's wrong to do that. They're saying it's wrong not to do that. And I think the experience you just said, Rich, with going to the lab, they're just used to billing the insurance, collecting what the insurance pays, billing the patient the difference, and if they can't afford to pay it, they try to work out an arrangement, and if they can't afford to pay it, they write it off. And I'm not saying it's a perfect system. I'm not saying it's if there would be a better way of doing things, but that is the status quo in medicine today. And I think we can all think of experiences where we've been to the doctors and it's been kind of gray what you need to pay, and there's and then at the end of the day, it's just whatever you work out with them. So again, we could spend all day on this, but I think getting that through your minds that it's a little different. And I think, what are you going to do when you have a patient walk through your door who has decent insurance coverage, financial hardships, who needs this life-saving, life-extending service that you're going to provide? And do you just not treat them? Do you take the insurance and work out what they can for the whatever they can pay you, or do you tell them to, hey, see you later and good luck with the rest of possibly your short life? I mean, it's really that serious at times. So I think you've just got to think about it, and because some of the things we're going to talk about, maybe at times it's appropriate to work out financial hardships with patients. Anything more on that you have, Rich?
The only thing I would add, Guy, that's good, is that you don't want your patient who has been coming to you for years, and then you tell them because they can't afford this and they die because of some sleep apnea related incident, cardiovascular incident or something like that. That weighs very heavy on a person's heart. And that's happened to me. So I know I can say that, I mean, we have 2 dental devices, guys, sitting in my lab right now that we took impressions on. We made the dental device and the patient died before we could deliver the device. And we keep them up there to remind us of how serious what we're doing is. So yeah, that's good, but you got to get through your head again that you're crossing that line from dentistry into medicine, and how this is done. We think about that. And I love your analogy there, Guy, of this can be life-threatening. And that's why the powers that be, so to speak, look at it from a different perspective. But, I do a whole lot of consultations every month, Guy. I'm sitting in my consultation room in my office right now, and I can tell you, every person that sits in that chair across from this desk has those same 2 questions. How much does it cost, and what's my insurance going to cover? And if you have a very definitive plan about this, then it makes the whole process go easier. You don't have a hiccup.
Right. Yeah, they want to know how much it's going to cost and how much in particular it's going to cost them. And this is not absolutely imperative that you deal with medical insurance. But if you want to work with the medical community and you want to send patients to physicians, have physicians work with you and send you patients, you're never, ever, never, ever, never, ever, never, never, ever going to develop strong medical collaboration relationships, whatever you want to call it, unless you deal with medical insurance. It's just not going to happen. You can treat your own patients in your practice for a cash fee. But if you want to start working with medical physicians and working with the medical world, and you want to help more patients too, I should say, you're going to have to learn some of the things we're going to talk about today. There's a lot of decisions here, Rich, that you and I have gone through this over and over again. What's your Medicare status? Are you going to be in or out of network? Billing systems? Are you going to do this in your own office, or we've already highly recommended you use another third-party biller? And again, keep typing. I can see some questions coming in. Type them in. We'll be answering them as we go, and we can hook you up with some of the third-party medical billers if you'll contact us. Again, you can put in consultation for that, or just we'll give you contact information at the end. But a lot of decisions, we could spend the whole hour on those decisions, but I think we're going to really hone in just a few moments on out-of-network billing. I think this part, though, is important. Some of you maybe have seen this before, but if you ask a dentist, say, what do you charge for a crown? I don't know if I've ever asked you that, Rich, so I don't even know what you're going to say, but what do you think most dentists come up with their fee for a crown or whatever they do?
That seems about right.
Yeah. They usually go, well, Dr. Smith, why don't you call Dr. Smith's office, attend your patient, and they call Dr. Smith, and he charges X for the crown. Well, I'm 20% better than Dr. Smith, so that's how I set my my crown fee. Or he's better than me. He's better than me. I'm gonna undercut him, $50. I mean,
yeah, so it's not very scientific, is it?
no, it's not. And we really should get a handle on our overhead and what we charge for our patients, so that we can meet our staff and our team's expectations, and pay everybody appropriately. But I recognize most offices don't run that way. So with that in mind, I think most of you would love to do dental sleep in your practices if you realize how much fun and rewarding it can be, and how you can really affect and extend your patients' lives. But what you need to do is make as much money or more than you're making doing whatever else you are in their patient's office. If you don't, if you're not making as much or more than you are in the patient's office, than you are doing other procedures in your office, then you won't do it. So this real quick exercise, and I'll try not to spend too much time on it, really will help you back into what a dental sleep fee you need to make you happy to do this. Now we'll talk about billing in a second, because billing may be different than what we actually come up here. So basically, you pick a procedure in your office that you like to do, and let's analyze that procedure, and let's subtract out any lab fees. So I'll actually just go to the next slide, and I'll put put the slides up here, and let's just say it's a crown. And it could be anything. It could be, if you like doing dentures, let's use dentures. Whatever you like to do and whatever you charge. So don't put a whole lot of credence into the dollars and cents here. But again, what we're trying to figure out is what dollar amount you need to make on average to make you happy to do this, so that you can continue to thrive in your practice. So if the crown was $1,300 and it took you 2 hours of chair time to do that, and maybe the doctor between the prep and delivery, whether it's CEREC or what have you, do it, you spend about an hour. And let's say you're spending a fair amount for your lab bill, $300. You have $1,000 left over after you pay your lab bill. So basically, at this point, you are charging $1,000 an hour for the doctor time, or $500 for chair time, depending on how you look at it, because you just do the math there. Now, if you're an active and productive dental sleep practice, we feel that, well, I don't feel, we know that you can get this down to 2.5 hours of chair time for your assistant, or 1 hour of doctor time per case. And Rich, I think, in most cases, once you get fairly efficient, you do a few dozen cases, I think those numbers are even lower than that. Do you agree?
Absolutely. You got to train your staff. If you train your staff and you delegate, staff can do an awful lot of this. So you might even be more, it's like anything else, right, Guy? I mean, how long did it take you to do your first crown compared to 20 years later? Of course, yes, you're more efficient, but I like the way you've done this, and it does put a little bit of science to it, for sure.
Yeah, and again, I think those numbers can be lower. So if we use higher numbers, then we're going to set the fee at higher, so we make at least as much or more. The first half dozen cases, maybe it's going to take you longer, but there's no reason with systems that we have at DS3 that you can't do a case from start to finish, including consultation, with an hour or less of doctor time and 2.5 hours of assistant time. No reason in the world why you can't do that. So if you just do this, if you want to go by chair time, you just basically take that 500 times 2.5, and it would be $1,250. If you want to go by doctor time, you'd be 1,000. I suggest that you average those two, or maybe put it a little bit more towards the chair time, because if you're efficient at doing this, crowns, you've got to spend half the time the doctor has to be in there in most cases, because they can't delegate cutting the crown prep in any state that I know of. But with this, you can delegate most of it. So again, you can strike that balance, 75 to chair time to 25, or somewhere in between. I just made it 50-50 here, and it came out to 1125 in this scenario. And let's take an average lab fee of $350. If you're a DS3 member, we get discounts at several labs, which basically pays for your membership if you just do it 3 or 4 cases a month. And that's $350 is more than most cases as a DS3 member. So we're putting that up higher. Then you'd want to say, look, let's just round it up to $1,500. I need at least $1,500 per case in my bank account to make me happy to do this. And so that could be your cash fee, or maybe you set your cash fee even a little bit higher, but you need to do that math so that you know. Now, the trick is, when we're going to talk about some of this medical insurance billing, you may get paid more on one case than on another case. And so you have to look at maybe 10, 20 cases to see that if your average net collections is hitting this number or not. Did I miss anything on that, Rich?
No, that's a very good point, because You know, I'm in network with some of these major medical insurers, and there's a $3,000 difference, Guy, between
Right.
what one does and the other doesn't. So that's a very good point, is look at maybe chunks of 10 or 15 or 20 devices at a time. And sometimes you're willing to do one for a little bit less. Absolutely.
Yeah, and don't expect the first 6, 10 cases. It's going to take you longer than that, but you can count that as part of your education. That's part of what we help you along. Just getting you started is important. We're not going to spend a lot of time on this slide. We've gone over this in past webinars because we really want to get to this out-of-network billing. But just understand, you always need certain things to file a claim, and you may need other things. And so you have to have a sleep test. You've got to have some clinical notes, which we do through DS3. If the patient fills out the portal, then it's all in place. You need to know if they have benefits, and we can do that with a click a button through DS3, or it requires a phone call. Letter of medical necessity prescription, proof of delivery form, and you have to have a method to submit the claim. Again, DS3 can allow you to do that yourself, or you can do it through your third-party billers. Most of the time, you do need a pre-authorization. It's on the May side over here. A pre-authorization requires a conversation with the medical insurance billing company. I'm sorry, the insurance company, and some sort of a form or paperwork you have to fill out. Affidavit for Medicare, if you're using Medicare. And you may need these practice parameters, photos of the device. So if anything on here you need more clarification, again, feel free just to contact us via phone call, or set up just, again, a free consultation, and we'll walk you through any of these questions, because I know I went through that fairly quick. Rich, you're in network in some and out of network in others. Can you briefly explain why you would be in network versus out of network, and concentrating a little bit on the benefits of out of network, since that's what we're talking about today?
Well, how you always ask me the hard questions, guys. So
I'm smart that way.
I mean, think about, you as a dentist, there are in-network plans and out-of-network plans that you can be, and what's the downside with an in-network plan? Usually it's you agree to a lower fee, but the upside is it costs the patient less, it's more efficient, you know exactly what they need, and it's more predictable. So now when somebody comes in network, Guy, and they have United Healthcare, we just click that button in DS3 and we get the VOB, and it spits back, hey, the patient's out of pocket is $395. That makes it easier, because you've already said the patient's going to ask, how much does it cost me? And what does my insurance cover? Well, in network, we know all of that stuff. That makes it a little bit more efficient and makes it a little bit better. So, and now we cross that line into out of network, and now we don't always know, because they won't tell me how much they'll allow. I go, well, will you allow 1,000? Yes. Oh, I'm sorry, I meant 10,000. Will you allow 10,000? No, they won't tell us, so we don't know. So we have to be a little more creative and a little more flexible. I love that word you have there, Guy. I think that's a good word. More flexible billing practices, The upside is you can get paid a lot more.
Right. That
bothers me, because you're down the street and you're out of network and I'm in network, and I get paid half of what you do. But you have to work harder, because you have to get a gap exception and you have to do all this kind of stuff. So most dentists are out of network. When you might become in network is if you are down the street from me, Guy, and I'm in network, then they're not going to give you a gap exception. That might be when, as a dentist, you say, okay, well, maybe I need to get in network. But right now, most of you don't have a dentist like me down the street. There aren't any dentists in network. So while we can, let's do this out of network and try to make more money doing it.
That's very good explanation. I'm out of network, and I'm not in network with any. I do have one insurance carrier that there is someone else in network. We can still bill that company as long as the patient has out-of-network benefits, but that's becoming less and less. And we'll explain a little bit about gap coverage in a minute in case you have questions. I see some questions coming in. We'll just keep typing the answers and answer at the end. We'll answer some out. Rich and I will, but we're going to keep typing some of the answers in as we go. So yes, that's a very good explanation. And just the take-home message is, out of network, you get paid more, very possibly, but you do not know how much they're going to pay you. They will never tell you the allowable amount. And I think for the rest of this half hour, we're going to talk about how you handle that part of it, because that's the key. We don't know how much.
Exactly right.
That's the piece of the puzzle that we're missing. And there's different ways of billing this. You can just do fee for service and say, look, I did that math a while ago, and here's how much it came up to $1,500. I'm just going to charge everybody $1,500. You pay me, wash my hands of insurance. And again, that's fine for some of your patients. You're going to treat less patients. You're going to help less patients. And you're certainly not going to work with the medical community if you do that. Now, your other option is you can check, or your insurance third-party biller can say, I'm going to accept assignment of benefits. And some of that money is going to come to me from the insurance company, and the patient's going to pay me the difference. Now, if you have a rigid fee and you never write anything off for the patients, what's going to happen is you're going to find yourself where they didn't pay what you think that they were going to pay. And then you're going to have to go back to the patient for the money, even though they thought that it was only going to cost them less than that. And so that becomes a problem when you say, hey, my fee's $1,500, insurance should pay $900, you're going to pay me $600. And when the insurance doesn't pay $900, what do? You go back to them for the money. Well, now they're upset. So if you raise your fee up and you're willing to take some risk, and it's a little more volatile, and you help patients out by taking risk and also by helping them with payments for financial hardships, then that's what I call a flexible system. And it's a little more diligent, a little bit more what we're going to talk about today. And lastly, we'll talk about, do you bill the E0486 just for the device, or all the appointments? For today, we're just going to talk about billing just the device. Billing all the appointments, probably, Rich, we should have a evaluation and management webinar in the future, especially with some of the changes we're putting into the DS3. That's a much more complex to build these other appointments. And I'm not saying don't do it, but that's billing, 505 instead of 101. So we'll get into that later. So for today's discussion, we're going to talk about accepting assignment of benefits in more of a flexible system, and only billing one fee for all of our patients to cover the entire treatment, at least for the first 3 or 6 months, depending on what you decide to do. So those of you who know me a little bit, know my background. I was in engineering before I went to dental school. One of the reasons I guess I fell into helping write software for our company, and at least algorithms. So I love stuff like this. I could stay up all night, making algorithms. So this may, when you first saw this, Rich, did you just want to turn the page? I mean, it's kind of confusing when you first look at it, isn't it?
Well, the first time I saw this slide, I thought, yep, that's Guy, But I will say that it makes sense, so right now this may not make sense, but in 15 or 20 minutes, you're going to have a much better idea about this. So, Guy he's a visual learner, and he sees this that way. And most of us are, in fact. And this is that patient that comes in that's out of network. So this is that flow chart that we're going to break each one of these arms down now. And we're going to say, okay, well, maybe we don't want to treat this patient. Maybe we do want to treat this patient, but this is the flexible system that we're going to use. So yeah, this doesn't look great right now, but it's going to make a whole lot of sense in a few minutes.
We'll break right down to each arm, and then we'll also go through this with Medicare. So right now we're talking about an insurance patient, non-Medicare patient for out-of-network billing. And by the way, if you want a copy of this, because again, we're going to go through it, but it looks confusing, but when we go through each arm, it's not. Again, put a consultation in, and Jody or Brandy, one of our trainers, will contact you, walk you through this, and give you a PDF copy of both of these if you want, because I know we're going to go through each arm, and then we'll come back to it so you can see it, but we'll be happy to meet with you and tell you how we can help you and give you a copy of this as a PDF. So before we can walk you through each of these arms, we need to establish 4 things. You need to establish what your cash fee is. So, that's probably the amount that you're happy to do this. The exercise we went through just a few moments ago, maybe it's that fee, maybe a little bit more. Maybe you say, I want to make a little bit more than I'm normally making for this, or just set it high enough that you're happy to do this. So if it was the perfect world and everybody came in, was, had deep pockets and could just pay you, what would you set your fee at? What are you happy to get every day for doing this procedure? And then we need to decide, what is a high deductible amount? At what point is messing with insurance not worth it? And I should suggest it's in and around your cash fee. If you want to just keep it the same as the cash fee, it keeps it kind of simple for your practice. But there's a dollar amount. If they have a $10 million deductible, this isn't worth messing with medical insurance for. And so I'm being sarcastic, but I mean, people do have $5,000, $10,000 deductibles. And then we have to estimate what the allowable amount is for our area. Now, your third-party insurance billing companies can help you with this. And this is that piece of the puzzle that Rich and I were talking about a moment ago. There's no way to know for certain how much that insurance company will allow, the particular one you're billing. We don't know what their allowable amount is. They won't tell us. They won't tell the patient. So we have to estimate, and this is why you have to have some flexibility, because we might estimate wrong what we think they're going to allow as far as the E0486. And then how much do you want to collect from the patient? And that may vary per patient. I suggest that oftentimes you at least need to collect a deductible or make payments on the deductible. They can pay that in payments too if they want. Or at the very least, collect enough to cover your expenses and lab bill, you know, $500-600 or something like that. And again, that could depend on the patient's ability to pay, how desperate the patient is for this treatment, and your office procedure. So for this example, we're going to set the cash fee at $2,500, and we're going to set the high deductible amount, and we're going to say the estimated allowable amount is $2,500, just to keep it easy in everyone's head as we go through this. And again, the deposit may vary, and I think these are pretty reasonable. I think an allowable amount for $2,500 is pretty conservative. A cash fee, I can tell you, if most of your offices, you did this every day and you got as efficient as we can help you be with this, $2,500, you're going to be making more money than you are doing most other procedures in your practice. So I think all these are reasonable. Do you agree with that, Rich?
I agree.
All right. So now let's break down this left arm over here first. So the patient comes in. We're going to first of all do what we call an instant, well, let me back up, an instant eligibility check. Now that you can only do, as far as I know, if you have DS3. We're the only company that has a connection with over 4,500 billers, and with a click of a button, you can find out if what the patient's deductible is for both in and out of network, how much is left of the deductible to meet, and what percentage the patient pays and the insurance pays for the dental device, the E0486. So with the click of a button, in about 10 seconds, you can have this information, 95% of the time on your patients if you have DS3. It won't tell you the allowable amount unless, you know, you're in network, and Rich, of course, as he explained, he knows the allowable amount, so he'll know it to the penny. So if you don't have DS3, it's going to require a phone call by your third-party biller or by yourself, where you have to wait and hold, and it could take as long as 45 minutes to get this information that we can get with a click of a button. So we've done that instant eligibility check. And in this scenario, let's say the remaining deductible is greater than $2,500. Rich, do you see the deductibles going up these days?
I would say probably only every other day. They're not going up every day now, but yeah, I mean, every patient that comes in, you know, we have this conversation, Guy. Maybe this is a good time to say this real quickly. Is we say, look, don't shoot me. You know, I didn't raise your deductible. I didn't do that. You know, because patients are angry. They're like, I pay all this money for this insurance, and now my deductible's going up, and we go, look, we're here to help you. You know, we're here to help you do all of that stuff. So you got to remember, patients sometimes can be angry because they're paying more for insurance, the employer's paying more, but the deductible's still going up. So yes, the short answer is deductibles are going up, and I don't see them coming down anytime in the near future either.
No, and they don't. And so if the deductible they come in is $3,000, $4,000, $5,000, again, in this scenario, we decided if it's greater than $2,500, you need to have I think the ambiguity of this is, what's a high deductible? Decide that, and then use this flow sheet. You know, if it's $2,501, you know, let's go on. Let's go down the left side. You've got to draw the line somewhere so you and your team don't get confused. The patient comes in, the discussion is, look, Mr. Jones, you have a really high deductible. They usually know that. It's over what we charge for our cash fee. It's $2,500. It's $3,000, and we charge patients who don't have insurance $2,500. So what we suggest is we're just going to charge you our $2,500 cash fee, and we can make payments, whatever you have, care credit, whatever your systems you have in your office for letting the patients pay. You use those, and say. And we're just not going to mess with insurance. The mistake I used to make, and I think this is important, I don't know, Rich, if you even heard me say this because I do more of this stuff than you do because I'm not in network, is what I used to do is a patient would talk me into filing the insurance anyway. And then you'd end up doing all the work. You got to pay your third-party biller for this. And so the discussion with the patient is, look, we're going to give you the cash fee, but what that means is we're not going to mess with insurance. Okay, that's because that cost us money, cost us time. if we're going to go cash fee, we don't mess with insurance. If you want to mess with it, it's fine, but we're not going to supply you with any information. We're just, you've got a high deductible. You figure out the payment, you collect your deposit, and this is just like a dental patient in a fee-for-service office. The mistake I used to make would be I would do the cash fee, they'd have a $5,000 deductible, and they'd still want me to bill it to the insurance company. It doesn't help them that much because they're not using out-of-network benefits for the most part anyway, so it doesn't even really help their deductible because their deductible out-of-network goes down. But now you've got you've set yourself up for a lot of work for very little payoff. So
yeah, it's oil and vinegar, guy. That's a good point. They don't mix. That's part of the reason that guy put this flow sheet together was, if this is the arm, this is the cash fee, it's discounted because we don't have to do all of that stuff.
Exactly. Right. And when we talk about Medicare, we may talk about a minimal fee. This is the fee I want to do this to help my practice thrive, but the patient has severe apnea with, 70 episodes an hour and they can't wear a CPAP and they're on financial aid and I want to help the patient out. Well, certainly I can take less than this. And you really need to know what your minimal fee is. I'll talk about in a little while too, to make a profit. And then there's also things we do, to help patients. I do cases for free. I do cases at a loss at times because it's the right thing to do. And that's a decision you can make. But from a running a practice point of view, when the deductible's high, we go just to the cash fee, and that means we wash our hands of insurance. We say it nicer to that than the patients, of course, but we're not going to deal with insurance, and they become a cash fee patient. So now we do that instant eligibility check. And great, the patient has good coverage. This patient has a $500 deductible left remaining for the E0486, because sometimes the deductibles for durable medical equipment, which was what we classify our devices, are different than their other insurance. So you got to make sure you know what you're doing when you're getting this. And again, click of a button, we can find that out if you have DS3. And then they have 70-30 coverage, which means insurance pays 70% of the allowable amount after that, and the patient pays 30. So what we now need to do is to plug in what our estimated allowable amount is. Again, if you recall, we decided we're going to estimate that the insurance company is going to allow $2,500 in this scenario. So we deduct the $500 from the $2,500, and so the patient's going to be responsible for 30% of the remaining $2,000 or $600 plus their deductible. So $1,100 if we're correct in our estimation. So what I came up with, I think I coined this term as far as I know, is a maximum out of pocket. The patient wants to know, what's the most this is going to cost me? And so I came up with a term called the MOP. That's what we call it in our office. It's the maximum out of pocket. I can set that at what we estimate this to be, $1,110. If we want to take a little bit of a gamble, because if they don't allow $2,500, I'm going to take a little bit of a loss. Or we could raise it as high if we really have an aversion to losing money. We could just always set it as high as the cash fee and say, well, the most you'll have to pay is our cash fee, $2,500. The higher you set that MOP, the less cases you're going to do, and the more patients you're going to walk out of your office and not get the care they needed. So that kind of comes down to an office policy. Typically, we'll look at the MOP, what we estimate it to be here at 1110, and I might set this patient at $1,500 and say, that's the most you're going to have to pay come the end of the day. And if they accept that, we can move on. And we can adjust that MOP up and down per the patient. But I hope does that make it clear? Because I know, Rich, you don't do as much of this. Hopefully, anything need clarification that I said there?
No, I think I'm actually the one that came up with that maximum out of pocket. No, I'm kidding. But no, I think that's pretty clear. And you got to realize that this is the flexible part of this. So, we're estimating, some of this you got to get. This is hard for dentists because they don't like to estimate, guy. They like to know. They want to measure that pocket. We're not going to estimate it, So this is a hard part for dentists to get. And I think you did a good job explaining that.
All right. And we're going to move on here. We might go just a few minutes over, but I think we'll be close to being finished on time. I see questions coming in. We're typing answers to those, so put them in the question box, not the chat box. We'll answer those, and we'll stay on to answer all your questions at the end as you need it. So now we've done this instant eligibility check. We've put the remaining deductible, and we calculated the MOP. In this case, we told the patient it's $1,500, maybe $1,200. What do we decide? If the patient says, yes, I'll do that, You collect whatever deposit of that mop that you feel is appropriate. You schedule the patient, but you don't start treatment necessarily that day because, as we mentioned, many of these cases need pre-authorization. Pre-authorization is basically requires that someone on the patient's behalf contacts the insurance company. Sometimes it requires a primary care to be involved, and basically the procedure has to be pre-authorized, and that's what really your third-party billers get paid their per case fee typically for. And it may take a day, and it may take 2 or 3 days. It may take a week or 2 even sometimes to get this pre-authorization. So you don't want to start, or certainly you don't want to deliver the device until that pre-authorization is completed. So you need ample time. Schedule them and make sure you don't deliver the device till the pre-authorization is completed and back. And if you want to be safe, don't even schedule the patient or schedule the patient out to allow time for that pre-authorization. You deliver the device. Now you're going to bill the insurance company. The payment's going to come back from the insurance company. Now you're going to know what they allowed for this particular case because it'll say it right on the EOB. And let's say they allowed, $2,400 or $2,600, and you billed. One of the things we haven't talked about is you might put your billable amount up higher than what that $2,500 is, so that you can have some flexibility there. Some people put anywhere from $2,500 to $6,500. I even know some people that put well over $6,500 as the billable amount. But what you do is now is you put the allowable amount in the ledger, whatever they allowed, and you deposit the check, and then you don't have to collect anything above what they allowed. So you can write that off in your ledger, the amount that they did not allow. If you billed a higher amount than that, if you billed $4,000, $5,000, $6,000, they only allowed $3,000, and then you tell the patient, then your ledger, you put the patient's payments in, and the ledger's correct, and you collect the difference up into the maximum out of pocket that the patient was agreed to. So the ledger kind of does the work for you. Any questions or things I didn't get on that, Rich?
I think you've got some numbers here in the next slide, don't you? Got the example, or?
Yeah, I think that's coming.
We are going to give a couple of those. So when we get to that point where we actually put the numbers on, I think, Guy, for most people, we might have done that a little bit fast, but we're going to do this again, okay? And this time we're going to do it where the deductible is less than $2,500. Remember, when Guy started this, he said you got to come up with these 4 or 5 things, and you got to figure out, what is a high deductible. So if we say it's more than 25 or less than 25, that was the case where it was more than 25. Now we're going to talk about a case where it's less than 2,500.
Right, which I think, and again, I'm glad you're on here if we didn't make that clear. So if the remaining deductible is less than 2,500, we just basically calculate that MOP. And let me back up. I think there's the numbers that we're talking about. In this case, we estimated the MOP to be, conservatively 1,110 and up to the cash fee. So in this case, I would probably tell the patient, I feel pretty comfortable because I'm billing more than 2,500, and we're going to accept whatever the insurance allows is one of the, I think, the key terms that I probably have forgotten to mention. If you bill more than the 2,500, what we tell the patient is, look, we estimate the insurance company to allow 2,500. We bill this at $3,000, $4,000, $5,000, $6,000, whatever your billable amount is, and you need to leave that billable amount the same for all carriers. You can't move that billable amount up. Let's say we put the billable amount at 5,000. We tell the patient we're going to accept whatever your insurance allows, and the most that you'll be out is whatever we calculate with this MOP. And so if they allow 2,500, then it's 1,110. And so we don't know that amount, and you have to understand there's risk tolerance there. You can move it all the way up to your cash fee. In most cases in this scenario, I would say, let's put it at 1,500. If the patient says, okay, the MOP, so here is 1,500, and we say, yes, they agree that, because I don't think I have the slide there that you're thinking of, Rich. So sorry. The MOP, I should have put that number in there, 1,500 for this scenario. And the patient agrees to the 1,500. We go ahead and collect whatever deposit. We schedule them. We do the pre-authorization, but make sure we get the pre-authorization completed prior to delivering the device, and ideally before we schedule the patient. Now, when the insurance comes in, and let's say they allowed $3,000, I don't have the math on the screen, but you just go back, it will say exactly what the patient owes out of that, and you put that in your ledger, and you write off any differences above what they allowed, and then we would calculate what the patient owes based on what they truly allowed, unless it goes above the maximum out of pocket, and then we tell the patient, look, it was a little more, and if they can't afford to pay that difference, then we write that off in our ledger. I know it sounds a fair bit of.
Let me add, Guy, that the reason, okay, so that's a little bit confusing. We're going to go through this again so it'll make a little more sense. But the reason we're calculating this maximum out of pocket is because me as a patient, I now know that that's the most I'm going to pay when I go see Dr. Yatros and he makes me a dental device.
Right.
That you cannot underestimate, Guy, how important that is for me as a patient. Because if we don't do it this way and we say, well, we're going to bill $5,000 and whatever they allow, you know, your part can be anywhere from, you know, $1 up to $5,000. Well, that makes me very uncomfortable.
Yes.
But if I determine what that maximum out of pocket is, and I say, look, Rich, you're not going to pay any more than this $1,500. I'm taking the risk on the insurance side of what they'll allow because they won't tell me what they will. I teach my people to say we are taking the risk on the insurance side. For some reason, that seems to, in the patient's mind, it's like, oh, well, this guy, he's a really nice guy, you know, because we don't know what they're going to allow. So that's what you've got to remember as a dentist doing medical billing in this particular situation where it's out of network is,
right.
You know, we don't know what they're going to allow. So we're making the patient feel comfortable that telling them, look, this is the most that you will have to pay.
Right.
And they're
Maximum
more likely to move forward with treatment when we do that. Okay, what's the next?
Yeah, and I want to back up just so we understand. And the way we come up with the MOP, just because I think this is the most confusing part of the whole topic here, and I see some questions coming in, which we're answering hopefully right now, is because we do not know this allowable amount, this $2,500. Again, that's one of the 4 decisions you have to make. What are we going to estimate they're going to allow? In this case, we use $2,500. So if we were correct, then this $1,100 that the patient would have to pay would be absolutely on the nose. If they allow $2,500, then we're absolutely correct. If they allow $3,000, it's a little bit more. If it's $2,500, it's a little bit less, and we're going to make less money. So that's one of the reasons that sometimes we get more money one case and less the other. That's why if you're willing to do this, I love what you said. We're taking the risk by capping the most out of the pocket of the patient, because if you don't do that and you just tell the patient, look, we're going to bill this at $5,000, $4,000, $6,000, whatever your billable amount is, they usually won't cover that, but whatever they allow, we'll accept. They like hearing that, but then we say we don't know how much it's going to be until then, and they need a finite number that they know is the most it's going to cost them, and that's what we're doing by doing this. And so when this all comes back in, and once they've delivered the device, and once the EOB, explanation of benefits, comes back, you get a copy of that from the patient, and it tells how much they allowed. Then and how much their amount is. And if you told the patient, I'm not going to charge you more than $1,400, and the patient's benefit is $13, is what they have to pay, and the insurance pays the rest, then you just charge them the $13. If it says that they're out for $1,500 and you told them the most they're going to be is $1,400, say, well, our math was a little off here. We estimated, but again, we took the risk, so we'll take it on the chin for the $100. I think that hopefully made that all clear, and understanding that's why you have varying amounts, and one of the reasons that you want to set your billable amount up a little bit more if you're taking some of that risk.
Yeah, and the only other thing I'll add to that, Guy, is this is where third-party billers earn their money too, because they're doing a lot of claims for a lot of dentists, and I guarantee you that whatever insurance company your patient has, they may have filed the claim. They may have a much better idea about what that allowable amount is. So that takes out some of the guesswork, because we're guessing what they're allowing.
Yes.
To come up with this maximum out of pocket. So we're trying to figure something out here when we don't know what some of the variables are. I think if you just get that through your head, then we just have to pick a number and put it in there and then make it work with that. And later on, we actually get what the number is, so we can go backwards and do the math. and we have to be flexible to knowing that we're only going to have the patient pay X amount, and all of the rest of that that's out here, we hope that the insurance pays all of it.
Right.
And then the patient could get some money back, but if they don't pay any of it, we don't ask the patient for any more money. We took that one on the chin. That's right. That kind of hopefully simplifies that a little bit.
And what I want to emphasize is what we started off with. One of the reasons we set our billable amount higher is they allow, most insurance companies allow a fair bit more per case out of network. So sometimes we do get 3, 4, if you set your billing amount for, I'm not telling anybody what to set your billing amount. That's why I'm kind of going all over the board with it. You need to set that yourself. But whatever you set it, if you set it $3,000, $4,000, $5,000, sometimes they allow that. So we end up getting, maybe 1,000 or 2 more than what we really need on some cases. On some cases, we get a little less than what we need. But it all works out to where you average oftentimes more per case out of network billing than you do for in-network, but it's a little bit more hassle. So let's go back.
Let's keep going though. We're running out of time. We're already getting over, guys. So
calculate the MOP, and let's say we approached them. We did this again, and we told them it was $1,400 because we estimated at $2,500, and we went a little higher just to be safe. And they said, I can't afford that. Okay, well, you can go down the right side of this, and you can stop treatment and say, well, then this isn't going to work out. The other option is you can try to get what we call gap coverage. You can try, and we mentioned this earlier, and what that is if the patient has in-network benefits and there's not a provider like Dr. Drake in your area, then you can apply for gap coverage, and then you can do it as an in-network provider for just this one case. And that's where your third-party biller really gets
earns their money.
Earns their money. And if they can get gap coverage, then oftentimes the allowable amount's a little less, but you'll know maybe what it is, maybe not, but at least the patient's deductible now, because some of the times their deductible's been met in network and they have a $2,000 out of network deductible has not been met. And so you can go down the path of gap coverage if you can't work it out of network with them. And I guess, the other option is to reduce your fee to help a patient out. I don't have an arm for that, but of course you can always reduce your fee to help a patient in need. So if you get the gap coverage and the pre-authorization, then you go ahead and schedule it and deliver the device. So again, those are the arms for out-of-network billing. The left one there is if the high deductible, we walk down if they agree to the MOP, and then if they don't agree to the MOP. And again, if you want more information on this, we're happy to meet with you. Just type in consultation, and we'll even supply these flow charts for you if you desire. And we're going to go into Medicare quickly, and we have, we've got about 4 minutes before 9 here, at least it looks like to me. We're going to get through this. We'll run about 5 minutes over because actually Medicare is a lot easier. And we'll stay on to answer some questions, keep typing them in, and we'll get to them when we can. The quick answer on Medicare, we've gone through this in many of our past webinars, so maybe this would be a good opportunity just to kind of glaze over this. We recommend that you become a non-participating Medicare provider. There's 3 options you can be. You can opt out, participate, or non-participate. And if you become a non-participating Medicare provider, there's certain guidelines you need to follow, and we're happy to supply these to you. But if you're not already a Medicare provider, this won't mean a whole lot to you. So I think I'm going to kind of coast over some of the Medicare. Here's where you get your Medicare application, and your third-party insurance billing companies will help you with this for a fee. And if you just want more information on just where you go, here's where you go. And again, if you want a consultation, we can at least tell you a little bit more about doing it yourself, but we really recommend that the third-party billers help you with that. So we have a separate flow chart for Medicare patients, and this will go a little bit quicker because it's actually a fair bit easier, and we highly recommend that in most areas that you become a non-participating provider, because if you don't, you're just leaving money sitting on the table. Just like out-of-network billing, you're going to need to establish several things before you start talking to patients about fees for Medicare. Cash fee we already talked about. Minimal fee I touched base on, but basically in our office we have the fee we'd like to have, where we're the most profitable and where we really want to be, but we also have a fee where we still make money. We've done the math, but it's not as much as we'd like, but we're willing to accept that as opposed to just letting a patient who needs care walk out the door. You need to know the Medicare allowable amount, and the good news is You can find that out. There's 4 regions. They're called LCDs, and we know what that allowable amount is, and we can help you know what it is in your area. I didn't put it in the slides because it changes, and so these are archived, and I don't want someone to get the wrong information. And then you need to calculate the MOP. So the big question mark, Rich, that we talked about before, we know the answer with Medicare, don't we, for the most part?
We do, with just a couple, again, your third-party biller will have this. Those of us in the South, Texas and Florida, we have the lowest. I know that, there are people in the East that it's almost twice what we get here in the South, right, in the Northeast. So, and again, those are changing. Hopefully those will be more equitable across the country. But we've taken one piece of that puzzle now, which is that allowable amount, and we now know it. So right, that makes our calculations easier.
Absolutely, and we're going to use this as a scenario. The cash fee, again, we're going to leave at $2,500, but maybe our practice is still profitable at $1,500. We'd rather have $2,500, but at $1,500, we'd rather help the patient out if they just really can't afford between insurance and Medicare and so forth. So that's where we set that. And then here in Florida today, and again, I hesitate to publish this because it changes, but it's roughly $1,070. Is what the estimated allowable amount is. That's why I plugged that number in. So if a patient walks through my door, I can tell them, look, our cash fee is $2,500. $1,070 is what we expect you to get if you have supplemental insurance, which most everyone do. If they don't, you're going to add 20% to this. But most of the time, the patient's supplemental insurance will cover the 20%, and the Medicare covers 80% of $1,070. So I can tell the patient, look, $1,430 is what your MOP is going to be, and we're pretty confident in that, and we're getting our fee. And again, this isn't what I necessarily charge, but this is just some scenarios for you to look at. And so if the patient can't afford that $1,430, then we can say, we still make a profit and we can help someone out just shy of $500, $430 in this case. So somewhere between $430 and $1,430 is what the patients are going to have to be responsible on their end to be seen in this scenario. So we have a different flow chart here, much easier. We'll be finished through this in 5 minutes. We'll run about 5 minutes over, but this is much easier. One of the reasons we highly recommend you get involved in Medicare. We're going to go down each of these arms, and we've established again the cash fee at $2,500, minimal $1,500, and the Medicare allowable amount. So the cash fee here at $1,430. I mean, this is minus what the Medicare is going to pay. We know that the patient what that amount is, and we can just tell them, look, we're going to file your insurance. Your supplemental is going to pay. The checks are going to go to you. If you're non-participating, you do not check accept assignment of benefits. The patient's $1,070 between the 2 checks is going to go to them. We're going to ask them to pay us our cash fee, which is in this scenario $2,500. And at the end of the day, when they deposit those other checks, they're going to be out $1,430. And if they say that's fine, then we just go ahead and get them scheduled. Again, you can make payments on this. They don't, if they don't want to come up with the full $2,500, they need some time, or they need to wait till some of that money comes from Medicare. That's up to you and your financial coordinator. But isn't this a lot easier, Rich, than out of network billing?
Yes, it is.
Yeah. So we know the allowable amount. That's the difference. And again, if you need to know the allowable amount for your area, just type in consultation. We can talk to Brandy, Jody, one of our insurance experts can help you understand what it is in your area. You can even Google it, and you can find that information out. But now let's say the patient says, look, I understand I need this. I've had a lot of other medical expenses. I can't afford $1,430 out of my pocket. My team knows that they can reduce that if the patient really needs care, and we want to help them down to a little less than $500. We usually will say $500 out of pocket, because I actually believe the patient values the treatment if they pay a little something. And if they agree to $500 out of pocket, $430 would be the minimal it would be, then we go ahead and schedule them, because we're still making our minimal fee there. So it's rare that we have a Medicare patient who declines treatment because if they really can't afford it and we want to help them, we're still making a profit. Again, these aren't my exact fees, but in this situation, the patient's going to be out $500 or less out of pocket, because we knew that minimal fee. Because again, the math on that was just, if we go back, I know it's confusing here, there's where you get the math on, again, the $2,500 cash, $1,500 minimal in this scenario, and we know the allowable amount. That's the big difference. So we know the $1,430 or we just subtract the 1,500 from, I mean, it's 1,070 from the 1,500 there. So that's that arm. And then the last arm of this is if the patient says, look, I can't afford anything. I just can't afford a dime, and I'm not going to do this if I have to pay anything out of my pocket. The neat thing about being Medicare non-participating is you can participate on a case-by-case basis by checking the accept assignment of benefits. Now the patient doesn't pay you anything, nor can you ask the patient for anything. And they say, no, here, you're going to go down this route if you want to, of saying, I'll accept the assignment of benefits, and realizing you're only going to get whatever Medicare allows in your region. The checks from both the Medicare and the supplemental will come to you. If they don't have supplemental, you can ask the patient for their 20%. I said that's can, it's not, you're allowed to, in other words, to ask the patient for that, but most people have that supplemental insurance. So you'll get those checks coming to you and you can begin treatment. Your other choice is to not treat them. Rich, when do you do this? When do you accept assignment of benefits? And do you do that on occasion?
Sure. When a little old lady comes in, I just fall in love with her, man. And I think, my gosh, you know, I had a lady the other day, 92 years old. And she said, well, I get $1,700 a month in Social Security, and that's what I have to live on. And I just fell in love with this little old lady. And I said, hey, we're going to make this lady a device and we're going to treat her. So now we accept assignment of benefits. I can do this where it doesn't cost her any money. Sometimes we get them to pay $10, you know, because I really do believe, like you said, Guy, you know, $10 for some people is like $1 million for other people. You know, I want them to reach in their pocket and just pay me something, you know, even if it's $10, because they tend to value it more. And it's almost like if they just pay nothing, there's not as much value there. So, but yes, we do this on occasion. And the nice thing is that with Medicare, if you decide to do this, like Guy said, so we don't opt out. We are a non-participating provider. We fill out the 855S to become a DME supplier. And now I can participate or non-participate on a case-by-case basis. And because I have made those choices, I have the choice to participate or not participate.
And the other time I'll do this, Rich, is I've gone and I've taken my time and my team's time. We've maybe gone and met with a physician who's new to the area. We tell them that we work with insurance companies, and he sends a patient over who needs a dental device, who can't wear their CPAP. And that patient said, oh, I heard you accept Medicare. Maybe on that case, I'll just go ahead and accept assignment of benefits since it's the first case that came from that new referral source, and just to make sure everything goes smoothly, make sure the patient says yes to treatment. Just first maybe 1 or 2 cases that come from the new referral source, just so the word gets back that, hey, this is a great office to go to. So you can accept assignment of benefits when the patient needs it, when you decide it's the right thing to do, and also it can help with your building your referral sources. So again, if you want copies of these flow charts, we'll be happy to, if you meet with us for a consultation, to provide those to you. I know this subject's a tad bit confusing. Hopefully we clarified it. Getting paid for saving patients' lives is one of the most exciting things you can do in your practice. I mean, it's just rewarding. Rich already talked about how it can be life saving, and when you don't get to it soon enough, it'll be non-life saving. So it's important that we do it. But I can honestly say there's nothing you can do in your dental practice that has a better return on investment, a more likelihood of making your practice more profitable. Implants, veneers, I've done it all in my practice, and never, none of the procedures I added to my dental practice came anywhere near adding the revenue that dental sleep can. And you just look at the numbers. If you just do a very average amount per device, the $2,500 with a $350 lab bill, even if you're paying a third-party biller, you know, as we recommend, a couple hundred, $250 a case to do your billing. If you do a case every other month, you can add $7,800 to your total net income. You do one a month, you're adding $19,000. I always joke you can take your kids to Disney for a day, or maybe 2 for one case a month here in Florida. Son's about old enough to outgrow that, but place is expensive. You know, you do one every other week, it adds 42. You know, you do one a week and take 4 weeks off a year, you're pushing 6 figures, or 87 grand you're adding, and you have to not try to be doing one of these a week when you consider that 1 in 5 adults has apnea. So the financial end of it, that's not why you should do it, but it's absolutely there. You need to have a plan for this. It's not, as we saw, hopefully we didn't confuse anybody too much. I'm sure we helped a lot of you understand this better, but it is confusing. There's systems that you need, and that's what we do at DS3 is we help. And if you are struggling with this or just want to learn more, just type in consultation, consult, if you want for short. One of our trainers, we have a team of, we call them our member support experts, and they're dental sleep experts. That's all they do. They come every day to work to just help dental offices succeed at dental sleep. That's their full-time job. They know more about dental sleep than the vast majority of the country, and they'll be happy just to meet with you, understand your challenges, give you some real valuable information. Of course, we can tell you how we can help you along the way as well, but they can clarify anything that we went through today as well. I got this fortune about 3 or 4 months ago. I was with Jason, one of our team members here, and we just thought this was hilarious, Rich, because one of the things I find, and you call it an aiming problem instead of shooting, I've heard you say, but you see these dentists that say, yeah, I'm going to do this, and they just feel like they're not ready. They're not ready to get started, and they spend all their time preparing and not doing. And the fastest way to get involved in this is just start doing it. Don't spend your time, I thought this was funny, spend your time stringing and tuning your instrument. Let's get out there and start playing. The sooner you start playing, the better you'll get. And yeah, you'll hit some wrong chords along the way, but you'll never be good at playing unless you play. And I think that we would love to help you with that. I know I'm kind of going quick because we're a few minutes over. We're typing the answer to some questions. We're going to answer a couple more here in a minute. If you want to learn about devices, this is one of my favorite ones, Rich, that we do once a year or so, and we got some new information about some new device changes. Looking forward to this one as well, aren't you, Rich?
Yeah, those are good questions. I think that's, these are the questions I think sometimes, Guy, that keep a dentist from doing this. They're the ones still, tuning the instrument, so to speak. Yeah. And what I like to teach is you can't make a wrong device, but you can make a better device. Right. So that might get you over the hump. Just pick one, just pick one and do it. If you team up with us, we do a lot of this kind of stuff, so we can help you with those cases. I love this magazine, this Dental Sleep Insider. It's an online digital magazine. You can subscribe to us if you want to get your email into this. We can let you know. Man, we've got some great content in there, and I hope you guys will take advantage of that.
Just sign up, and you can even see the past videos, articles, and here's what we do. We'd love to help you. We do also have courses. I mentioned them earlier today. If you came on a little bit late, we have courses throughout the country that are the most practical dental sleep courses out there. I can promise you'll not take a better course if you want to just implement this. And if you type in course, we'll give you a discount for a one-day course. I think we're giving $100 off. And if we're a 2-day course, I think we're giving $200 off. If you just type course, you can secure that discount as well. So there's how you get a hold of us. I see quite a few questions we've answered, Rich. I think we'll stay on for a couple more minutes here and answer a few of these. One I don't think we've answered there is how long does it take to get paid? That's just my favorite answer to that is it depends. What would you tell people about that, Rich?
Too long. Yeah. In general. So we get paid from some payers, Guy, in 2 weeks, and some we're still working on from 10 years ago, I feel like. So most of the time, at 60, 90 days, if you're being diligent, you're following up with this. And again, this is where a third-party biller is worth their weight. Remember, most third-party billers get paid about 10%. This was another question there too, Guy, about what do you pay a third-party biller? Most of them get paid about 10% of what the check amount from the insurance company is. So it's not 10% of what you bill, it's 10% of what the insurance company pays. So if you bill Blue Cross and they only pay $1,000, then that third-party biller would get paid their percentage. So and some of them are a little different, the percent of what they get paid. But most of the time, 60 to 90 days, we're getting paid from insurance companies.
Yeah, and I'll mention those third-party billers typically have a per pre-authorization fee or per case fee to make all those phone calls too. So typically, one of the companies that we highly recommend for pillar billing is works with DS3, and they charge $49, I think, dollars currently, plus the 10% of what they collect. So they want to, if they don't collect any money from the insurance company, they've pretty much lost money for all the efforts that they put, so that they have a real strong motivation to collect the money. And we work with DS3 works seamlessly with at least a half dozen that I know of third-party billers. So one other question: can you bill for snoring? And the answer to that quickly is no. The patient has to be diagnosed with obstructive sleep apnea, before you can get paid. In particular, obstructive sleep apnea. Central sleep apnea, which is not very common, you may likely not get paid for that either. So I know we've answered a lot of the questions. I see a couple more coming in. One about sleep testing. How do we get a diagnosis and get sleep tested? We've done past webinars on that. Again, if you want to answer some of these questions that we don't get to, just type in consultation, and one of our trainers, member support experts, will meet with you, answer some of these questions maybe we don't have time to get to. You and your team, it'll be well worth your time. But the short answer to that is that you have to have a diagnosis, and that could be through home sleep testing or through in-lab testing, and we will, I'm certain, do another webinar on that. We've done quite a few in the past on that subject. So that's the
let me add one thing to that, Guy, too. And again, we're not pushing for third-party billers, but until you learn a lot of this stuff, you just don't know what you don't know. But, Aetna, for example, Guy, in my area, you can have a sleep study and you can actually be diagnosed with sleep apnea, and they won't pay for it because you didn't meet the minimum criteria, which is a certain number of events and a certain time frame and things like that. So remember, you got to get people sleep tested. So we talk about our 4 pillars, and we walk a patient from when they walk in your office. How do we screen them? How do we identify people at risk? How do we help facilitate that sleep test? Which device do we make for them, and how do we get paid? So we just did one of those things tonight, which is that. The next webinar will be on which dental device you make, and dentists, they want to know that. So we'll talk about, the bite. Is it forward, back, shallow, deep? Do they grind their teeth or not? Do they have TMJ symptoms? How big is their tongue? How narrow is their arch? How severe is their sleep apnea? We can control vertical and we can control protrusive. Where do we start? What do we do? Those are all of the things that we're going to talk about. And Guy and I are dentists, we love that stuff too. We had to make ourselves learn this other stuff because these things.
Yeah, I like that webinar a lot better than this one, but this one's arguably just as or more important. I see one of the questions is which are the Medicare devices. We'll go over that as well. The quick answer: the 2 we use most commonly are the TAP and HERPS, but we'll get into more detail on that as well during that course. So lastly, if you want to talk to us, then again, here's how you get a hold of us. You want a free consultation, type in consult. And then again, if one of the courses interests you, I promise you'll be happy you went. Type in course. It doesn't obligate you in anything, but at least secures that discount we talked about. Rich, we ran a little bit over tonight, so I think we're continuing to answer some questions here. Looks like we're getting most of them answered. If you have more questions, we're more than happy to answer them via email, phone, or the consultation. But I think it's late here in Florida. It's after 9, so I think we're going to sign off and see you at the next webinar on dental devices, unless there's any of those questions that we didn't get to. You think we're good, Rich? Anything else you need to say?
No, we're good. Thank you, Guy, for putting that PowerPoint together. That was a good job, and we hope we didn't confuse you guys. Remember, as a DS3 member, we go in and we archive these things. You can listen to it again. You can have your staff listen to it, so you don't have to reinvent the wheel. This is what we do. We help dental offices succeed, and we hope to see you at one of our courses or at the symposium or certainly on the next webinar. So thank you guys for joining us tonight.
Have a good night. Thank you.